the General Practice podcast from Ockham Healthcare, supporting innovation in general practice.
Hello and welcome to the General Practice podcast. I'm Ben Gowland. This episode is brought to you in partnership with Practice Index. We explore the implications of the 26-27 GP contract and its impact on practice finances. Learn how Benchmarking Manager in the Practice Index Hub can help you assess your practice's current position, identify key financial priorities, and focus on the areas that matter most. Head over to practiceindex.co.uk to find out more. Welcome to the podcast. Today, I'm joined by Claire Houston and Robyn Clark. Welcome both. What have you been up to? Have you been busy, Claire, since the new contract came out?
Oh, we're always busy. We've done a few bits and bobs really in terms of updating, in particular updating the hub. So we're looking at things along the lines of we've released our most recent set of benchmarking figures, which is always quite interesting, I think, for practice managers to see, in particular, obviously in England, but to see where they're up to and how that's going. We're in the process of updating all the R's figures so that we've got some good calculations there. Lots of activity around the salary calculator and holidays. And we've got a fantastic new module called Signed Documents, which helps manage documents that need to be signed within the practice. I think lots of practices are using that for PGZs as an example. So we've been really, really busy, as we always are at this time of year.
Sounds great. And Robyn, have you managed to get a holiday so you can digest all the details of the contract?
Oh, yes. I had a lovely Easter weekend in Spain, and what I did not do was think about work once. But then I did have last week off, and I did, of course, get a little bit embroiled in having a look to see what's going on and what we need to do to prepare. And I do have to just say, in support of the Practice Index salary calculator, is so helpful because the 1st of April, we had to uplift everyone's to the national living wage because that changed and we had no choice. So that was really helpful in calculating what that was going to impact the practice finances with. And then obviously it's there to help you with DDRB recommendations, which I know we're going to talk about. So another props to the PI team for creating stuff that really helps us do our job.
Yeah, we're going to talk today about the sort of financial changes in the new contract and what impact that's already starting to have on practice and what impact you think it's going to have through the year on practice. So let's start with the kind of what you think about the overall settlement. The headline figure was 485 million. It's kind of half, I would say, of what was there last year. But I guess last year they had to take into account the changes to national insurance. What was your kind of sense of how general practice fared as a result of that?
Not great. I think when you actually take into account all the various changes to the different funding streams, it actually only really represents a 1.4% increase in actual real terms funding, which is insane because inflation is still higher than that. The DDRB recommendation is higher than that. All of our costs are going up. The national living wage uplift was 4.1% in itself. It feels like last year, things were starting to look like we were going in the right direction. And I feel like it's almost we've had a complete U-turn in terms of the financial support that general practice is being given. And along with that, this whole renewed focus on just seeing everything urgent on the day, how are we supposed to manage that level of demand with no significant investment?
What did you think, Claire, in terms of just that ability of the settlement, just as a start, to be able to cover the increases in the salaries? Because we've had the DDRB come back since that was published saying it was going to be 3.5 instead of 2.5%. So if you've basically got that, we'll say FC at 3.3%, like Robyn says, you've got minimum wage going up by 4.1%. Feels to me that's the money gone already, isn't it?
I always crunch the numbers before we chat, Ben, because I know you're always going to ask me some interesting questions. I think it's one of those things that it very much depends on the makeup of your practice, the types of roles that you've got. If we look at a GP earning, roughly speaking, the sessional average across 9 sessions, so an FTE GP on a sessional average for salaried GP, the actual cost to the practice for just implementing that increase is about £4,500 for one GP. That doesn't take account of anything else they wanted to do in terms of, moving that GP on forward in terms of their level of experience or responsibility that they've taken on. In terms of our normal FTE staff, so somebody on minimum wage, it's sort of around about the £1,500 mark. And I think that's the real challenge, is that actually the funding doesn't go very far. We are going to see, I think, given the level of challenge we've got at the moment, a pinch point in the sense that we can see the wider crisis in terms of energy, again, is going to rear its ugly head. And for practices, it's an unavoidable cost. We can't have buildings that are cold. We can't avoid those costs. And it's almost like we're just expected as practices to absorb that cost without any wider context in terms of what sort of support that might look like. And I think that's the real challenge, is that we've got the wage cost pressures. Obviously the government say, well, we fund those increases, but actually the BMA asked us to work with them to do a salary survey, a general costs survey really, to see where things were sitting. And IGPM asked their members to contribute, and we had quite a number of contributions to that. And what it really clearly demonstrated is that the NHS say, well, it's kind of 48% of your GMS global sum is allocated to your staff. But actually, for most practices, that really isn't in any way, shape or form representative of the actual total that they spend. So every time, and I've said this probably now 3 years on the run when we've talked GP funding, every time they say we fund it, actually, we're falling further behind. And it's almost like that message doesn't seem to be getting across. We know you think you're funding it, but actually, it really isn't happening on the ground.
Well, there's 48% on staff costs, which we know is wrong. But also, what about all of the other costs? You said about utilities, consumables, infection control, cleaning, all these other things that we have to have, plus all this focus on moving to digital. Hardly any of this digital tech they really want us to use is funded. We're having to fund that at practice level. When you're using 80% of your core on staff, which I think was around the average figure we came to from that survey, I mean, that's not including partners' drawings as well. This is the people who own them, run the business, and also the majority of which will provide clinical sessions themselves. We've then got all the running costs as well. It just doesn't stack up. And I just feel like we're constantly banging our heads against a brick wall to say, when are people going to realise that the funding formula is flawed? And I know they've committed to reviewing the Car Hill, but I don't know how much faith I've got in that process.
I think it's really difficult, and Robyn's hit on a really valid point there. We see increases in terms of utilities, we see increases in terms of staffing, but every single business that you buy from experiences the same cost pressures, so their prices will go up. It's one of the reasons we ended up with such large levels of inflation historically, and in the most recent number of years, is because of those cost pressures. Every business experiences it, so they put their prices up. Unlike a normal business, GP practices can't put their prices up, really. They're told what they're going to earn, and then they have to make that work. And given what's then gone into the contract and the changes that are being made to the contract, and in particular, when you have a lack of visibility of how funding is going to change sometimes, that's really quite difficult to manage.
On top of this year's settlement, you've got the historic that inflationary cost pressures weren't met for, maybe last year, but certainly the sort of 4 or 5 years before that, they weren't met. So you've got that cumulative pressure on practices that hasn't been taken into account. And I don't know what you think, Robyn, but it's like when NHS England or the government are coming up with the contract, they don't believe that those cost pressures are real, because there's some figures that are out, I think they were released this week, shows that the percentage of NHS funding going to general practice has fallen again. So now it's lower than it has been.
Yeah, I think sometimes we're victims of our own success, and we regularly highlight how general practice is the most cost-effective part of the NHS because of the partnership model. Personally, I believe that we make sure we run our businesses as efficiently as possible, reduce wastage, and maximise the resources that we have. But then it's almost like, well, general practice is so good at it, they could probably do it even more. We are as lean as we can get. There isn't really much wastage still going on. And actually now we're at the point where we're really struggling because we've got, estates that are crumbling around us. In a lot of cases, they're not fit for purpose anymore. We're lacking space. In my own practice last year, we had a water tank that was just became dilapidated and we had to replace. And that was £15,000 cost that we had to then find the money for as partners because it's our responsibility. But again, these things are just not taken into account when our funding formula is looked at. And I think we're an afterthought almost when it comes to the issues around rising inflation, the cost of electricity and everything. We don't get any support around that. And we've lobbied for it in the past, but it's always just been, well, this is just a business cost and you have to absorb it. But like Claire says, we're stymied by our contract because we're not your typical business. We don't get to pass that increased cost onto the customer to help us resource it properly. And it's about time that changes.
The one thing that the government and NHS England are pointing to is this shift of the capacity and access funding. So it's 292 million nationally from PCNs into practices so that they can appoint GPs. What do you make of that shift and what impact do you think that's going to have?
I've been banging my head against a brick wall about this because for me, it's a terrible idea. The capacity and access funding that's been used via PCNs up to now, the majority of which has been funneled almost directly to practices from the PCN to help them improve access. So in our PCN, it's divided between the practices. In my practice, we've used that to fund our online total triage system. We've used it to bring in AbTray software to help us maximize our call and recall and make sure that we don't duplicate appointments so that we can then free up appointments for patients. We're using it already to fund technology to help improve access. That cost is now going to come into our bottom line because the cap funding is not there to fund it anymore. And we can now only use that to recruit salaried GPs. And there are so many issues with that alone. I mean, where do you want me to start, Beth?
Well, I mean, we haven't seen details of the scheme yet, have we? I mean, we're coming up to May and we still haven't seen details of that scheme. So is that going to get published soon? Well, how's that going to work? How do you understand it?
So I believe it was supposed to be published with the SFE statement, but it wasn't quite ready. And I know the BMA are still negotiating elements of it. The points that are concerning for practice managers and that we have raised back via our IGPM channels. So first of all, is this recurrent funding or not? And we believe that it's not, in which case you have to be very careful what kind of contract you're trying to recruit to for a salaried doctor. I'm not going to be advertising a permanent post if there's a chance that the funding isn't going to continue. But as a PMS practice, I have to offer the BMA model terms of employment to any salaried GP. And one of those terms is recognising continuity of service. So if I recruit, say, a newly qualified GP, I have to recognise their service if it's unbroken from the point they started their GP training. So when I end their contract, if the funding doesn't continue, I have to make them redundant. And that means that I've probably only employed them for about 9 months, but I'll have to make them redundant for 7, 8, 9, 10 years worth of service. What practice is going to do that? Because that's a huge financial cost that the practice will have to bear and will get no support from. So I don't imagine there's going to be any funding we can claim back to pay for redundancy payments for these people. So that's one of the biggest glaring obvious concerns that we have at the moment. The other issue is if the aim of the project or the fund is to improve access to GPs, is it only salaried GPs, not locum GPs, not partner GPs? If you're a GP seeing patients, does it matter what kind of GP you are? If this fund could be used for locum GPs, I could have improved my access from the 1st of April because I could have got a locum in straight away. But if I want to hire a salaried doctor, I've got to go through a recruitment process. If they're already working somewhere else, they might have to give me notice. So it might be 3 months before they can even start. I have to train them up and induct them. So the onboarding process would also eat into that. So we're probably talking about 5 months before they're up and running fully. And then again, if I can only have them until the funding runs out, I might only get 7 months of a GP at full capacity. And then where am I going to house them as well? Because there's no space in my building. So there's all these concerns. And it's a fund of if you don't use it, you lose it. And it's not ring fenced for primary care as far as we understand. So if people don't use it, where does it go?
And there was also a rumour, tell me what you make of this, that some NHS Confederation report which was suggesting that it might depend on your existing GP to patient ratio. And if you've got a high GP to patient ratio, then you might have to go through some sort of ICB application process even to access the fund. Have you heard that or?
No, I've not heard that at all. We were working on the assumption that if the amount of funding was the same in totality as it was as a PCN, then we would assume that the same amount of funding would just be split down into your practice ratios. But again, we're still waiting for the detail of that as well. But that's also become another barrier to people recruiting because they don't want to over recruit. If they say, well, the document said it could be about an average of 5-session GP per practice, but actually their share of the funding is only, say, 2 sessions, then again, they've hit themselves in the pocket by over recruiting. Our LMC in our area has sent out advice saying we advise you not to recruit until we've got the detail because you don't want to end up shooting yourself in the foot, essentially.
What do you think, Claire? And could practices even end up being worse off because of this? Because with the Capacity and Access Fund through PCNs, like of the 292 million, over 200 million was not conditional. So PCNs could just pass that down to practice without the caveats of it having to be for GPs. It could be much more flexibly used, like Robyn's saying, for technology or for other staff. But now there's going to be all these hurdles, it looks like, put in front of practices being able to access it in the first place.
Interestingly, I have heard what you'd heard, Bud. It's going to be conditional on the basis of your patient to GP ratio. So I had heard that, which provides challenges for those practices who are under GP'd. Then perhaps that helps because the jobs will then follow where it is. I think it all really comes back to this same problem that actually one of the things in terms of having a longer term negotiated contract is that we kind of know what's coming. We've got some certainty. The problem we have is that what we're doing is not only messing with practices funding, withdrawing a set of funding from here. And as Robyn said, that prevents you then from using it for what you've used it for. So now we've got to find that. There've been, I think, some of the areas of dispensing have ended up with unexpected costs in the last few months that they weren't expecting to see because funding's been withdrawn for various bits of stuff that they're using. And we end up in this constant, we're now into April. We still don't really have 100% visibility of what's going to be expected. The neighbourhoods documentation has come through, which essentially says we're thinking we can probably use existing buildings in the main. And as Robyn has rightly pointed out, most practices are experiencing quite a lot of pressure in terms of just having PCN staff put quite a bit of pressure on practices because they've got somewhere to put, to find somewhere to put them. So the staffing is one problem. The estates is another problem. And then we've then got a few hoops that we need to jump through. And those hoops look different every year. I've always said, actually, QOF has historically been one of the more flexible parts because in the sense that each year, effectively, it can look completely different. This year we can decide we're going to do this. Next year we'll decide we're doing something different. And that is historically what's happened. Broadly speaking, some parts stay the same, but other things change quite a lot. But actually, we're looking at a contract now that changes quite significantly. We're going to do this, we're going to do that, we're going to do the other. But there's no obvious continuity of funding. Actually, we're going to do this and this will remain in place. You're not just messing with practices and their ability to manage things, but as a GP looking for a job, I've got no certainty. How do I get a mortgage on the basis that I've got a job that might last for 6 months? How do I, guarantee my family are going to be fed? And that is a massive challenge. And I think it's almost like we need a more protracted, more definite, this is how the funding is going to go so that we can make, as practices, longer term plans for this is what we'll do, this is how we'll do it, this is the journey we're going on. Neighbourhoods are coming along, we've got PCNs and neighbourhoods probably going to closely reflect each other. Okay, so we know that this is coming. Let's make a really good plan that means that actually we all move forward together rather than a bit of a piecemeal approach, which means every single year we have to think, right, okay, how do we change this and what are we going to do and how's that going to look? We've got a 10-year plan. Let's, look at 10 years. What does that look like?
The other change that I think is significant in the contract, so for advice and guidance, instead of that being an enhanced service with a payment for an item of service, what's happened is the total fund for that's been put into core, so that's now included in core, but it's become a core requirement as part of the contract. What do you think the impact of that will be on practice, I guess both financially and in terms of workload?
I think when I speak to my clinical partners, their concern there is it's shifting work back onto GP that isn't GP work. Using advice and guidance can be really helpful. It can, negate the need for a referral where one is not needed and save the patient a trip to a big hospital. It saves resources. I get that. But a lot of the times with advice and guidance, we ask a question where a GP is pretty adamant this needs to be seen by a specialist. And the response comes back saying, can you do X, Y, Z test in your practice? Can you look after the result? Can you basically hold this patient on your books to help our workload? And that's not what's right for the patient. And I think that's what is concerning for our clinical colleagues. It's just, they're not house officers for hospitals. They've become GPs. They are generalist specialists in that sense. And when they feel that a patient needs to be seen by a specialist, that is their medical right to do so. And is this starting to chip away at that right that's ingrained in law, actually, for doctors to make onward referral when needed, and that referral cannot be rejected? So I know the BMA are really hot on this one at the moment, recognising last year that A&G is extra work for practices, and that's why it was given extra funding. It's a bit disingenuous to then be like, okay, so that's been done, so now it's just part of your job. That sets, for me, quite a dangerous precedent. Do we try things like for only 1 year, and then who gets to decide that should become business as usual? What feedback has been sought from the profession on that?
Yeah, and I guess at a time when this contract wasn't negotiated, was it? It was decided by NHS England, and then they said this is what it's going to be. And I guess it could be worse because what it talks about is advice and guidance somehow become use of single point of access, which is just another word for referral management centres. So that sense of the amount of work that's going to go back to practices, you would expect to almost exponentially increase if they're having referrals rejected on an ongoing basis by these referral management centres.
I almost feel like the government's opinion of doctors has really gone down the toilet at the moment. So basically, a doctor, a qualified medical professional, determines that a referral is needed, but that referral has to be triaged because we can't necessarily trust that it's appropriate. Like, that is a really bad message to put out about a profession that where we are already struggling to recruit and retain staff, where we are trying to give the public confidence in seeing people in the NHS. When the government is seen to be kind of undermining that role and their value, it's really, really dangerous. Where do we get to as a society where we no longer trust the people that are supposed to be the ones that help us look after ourselves? We're edging into ever more sort of dangerous territory around that.
What do you make of it, Claire? Do you think practice, financially could potentially lose out from this because this shift from an item of service to it now being included in core?
I think even when the item of service was brought in, I didn't feel it was going to cover the number of advice and guidance requests that practices were going to need to make. I think sending everything via that kind of single point of access is one thing. I think the difficulty is, I was reading on social media a GP who basically said, I've been looking after this patient for a really long time. He's noticed symptoms in the last 6 months. We've been looking at that, internally, and we've done the things that we think we ought to do. And now I've decided that actually it's not something we're going to easily resolve. I think somebody needs to look at it. And I think, GPs are well versed in that kind of, they're really, really good at that level of risk assessment. Actually, is this something that we can continue to manage safely, or is this something that needs to move on? And actually, if we're going to end up with bounce back, referrals, can you manage? GPs haven't got the capacity either. That's the problem, isn't it? We're talking about urgent requests on the day. They need to be dealt with. How long is the wait going to be to manage those things? It's such a circular problem, and everybody's struggling with demand. There does need to be a wider conversation about how we as a nation manage our health. I think the government are trying really hard to make that case for proactive management. So prevention rather than cure. And that's really important. But actually, from a financial point of view, I think GPs can't, there is no capacity really for GPs to hold more of the workload than they already do. And it's not that GPs are trying to dump it into secondary care. It is secondary care work often that secondary care haven't got capacity for. It's not that they've got capacity either, but that capacity has to sit somewhere. The patients need to be seen. It's just about how that works. And I think in real terms, GP funding is sliding compared to secondary care funding and other parts of the healthcare system. If we're going to ask GPs to do more work, then fine, but the funding needs to follow. And I think that's the problem we've got. There's a bit of a disconnect between how it works in practice and what we're actually being expected to deliver at a practice level.
You can't shift hospital into community without shifting the resource as well. And that's just not happening.
The way that NHS England talk about that is they go, well, it isn't about increasing the work, it's about dealing with what they term unwarranted variation. So they're saying, well, look, this practice manages all this work. They do it fine with this ratio, so all practices should be able to do it. So really, what's not needed is more money, but more management of those practices. So that's what's coming across from the stuff that they say.
You can't standardise general practice. That also kind of flies in the face of this whole focus on neighbourhood. The neighbourhood is supposed to commission and create and design services around what its patient population needs. That is what general practice has done since its inception. So they can't keep flitting between, we want to be, recognising of individual differences but actually you need to standardise every aspect of your care, because that's not how it works. And I think all doctors work differently, or all doctors will look at things in a different way, or potentially approach a problem with it from a different angle. And we are supposed to respect that and acknowledge it. And it just feels like that respect and acknowledgement is not coming from above when it comes to how we structure our services. And all the messages that we get around how we're supposed to do that then become incredibly conflicting, depending on who you talk to and what the topic at hand is, and who are we trying to please. I feel like there's just not enough kind of letting us have our independence and run things in the best way possible, and trust in the systems that are supposed to be there to manage the quality of the services that we provide. CQC is there to inspect practices where there are concerns. ICBs as commissioners will know what practices are struggling or not providing a good service. These mechanisms already exist. Instead, what seems to be happening is we're trying to be managed via the contract, but the contract is actually putting restrictions on us that are going to make us be worse, essentially.
Well said, Robyn. Just to cover things off then, there have been some changes to QOF and the child vax targets. What do you make of them? Do you think they'll have an impact on practices?
Not hugely. I mean, I think there was some positivity in actually recognising that practices are doing astounding amounts of work to try and improve their adherence rates, and that often it's beyond their control. So now there is the option that if you can show some level of improvement, there may be some financial benefit to doing so. Where does patient choice come back into this? We cannot force somebody to vaccinate their children. It is not mandated in this country. And we are allowed to do a personalised care adjustment for declining a treatment for every other element of cough. Why not this one? And actually, by constantly pushing this with some people, it creates a barrier in the relationship between the patient and the practice. And that's something we definitely don't want, because we want these parents to bring their kids to us if they are sick, to come to us themselves if there's something wrong, and not to have this level of distrust. So it's kind of asking practices to fix a problem that actually the government needs to take more of a hard stance on if that's what they want.
Any thoughts on the quaff stuff, Claire?
Part of the issue from a funding and finance point of view is that I don't think that the actual indicator changes are going to make much difference materially. Practices have been banging the same drum for the last few years, really, in terms of the vaccinations. So I think what progress would have been made has already been made. I don't think it's lack of practice effort in that sense. I think vaccination, from my point of view, is really incredibly important. And I think the recent outbreak with the students in the south of the country really demonstrated how dangerous some diseases can be. But Robyn is ultimately right. I think the reason we don't have a patient choice indicator is because it isn't the patient's choice, it's the parent's choice. And I think that that's a distinction that perhaps is being drawn, although it's not explicitly said, because we do have it for shingles in that sense. But I think it's that real challenge of getting the messaging across that this isn't just beneficial for your child or not beneficial for your child. This is a population level issue. I just think it's a really massive challenge for some practices, and I don't necessarily know, it's a welcome change in terms of seeing a change to the indicator, because it has been a really big problem for lots of practices, but I don't necessarily know it's going to make much difference for the practices that have already been trying, and they will have been trying.
Really helpful. Thanks both. Just before we finish, Claire, just remind us then, so what support is available on the Practice Index site for practice thinking, how am I going to manage my finances through this next year when it does look like it's going to be a challenge?
We've got lots of information in terms of the forum, so we offer lots of support there. We have lots of plus documentation, so we're covering things like the changes to the PCN DES that looks at the impact of that. We've got blogs in terms of what you need to do for QOF. We've got the salary calculator. We've got the BMA survey. We've left the BMA survey open so practices at any point in the year can kind of contribute to that. We're trying to get a really good data set so that we are able to support the BMA and IGPM in really trying to explain to the government where funding is sitting and the challenges that they're experiencing in terms of those cost pressures. We do lots of help and support in terms of that benchmarking and in terms of prescribed drugs for those kind of personally administered items. So there's lots and lots of support that we offer for practices for PCNs, and it's just a case of have a quick look at the website and, if you've got questions, then any member of the team will be happy to help.
Fantastic. Thanks both. Really appreciate it.
Thanks.
Bye.
This episode was brought to you in partnership with Practice Index, who help support practices with HR, learning, finance, compliance and rotas all in one place, the Practice Index Hub. Find out more and book a demo by heading to practiceindex.co.uk.
The General Practice Podcast from Ockham Healthcare, supporting innovation in general practice.